after you finish.
Okay.
One more minute here. Okay, getting ready to admit everyone.
Good morning, everyone. We are seeing you coming in. There is a poll for you to complete if you would do that. Looks like we're good with poll 1. Are we ready for the second poll? That's slide 8. Are we done with this one, Aaron?
That looks like it should be good.
Okay. All right. Well, thank you for coming to the intersection of interpersonal and intimate partner violence and traumatic brain injury session. We're glad that you are here to learn more about this topic. My name's Carol Lipinski, and just wanted to give you a couple of heads up. One is that we won't be able to hear you or see you, but if you want to chat with us, please feel free to do that in the chat box. I will be monitoring that as we move forward. And if you could put questions that you have throughout the session in the chat, we will deal with those after the presentation by our doctor. I think we're good to go, Dr. Johnny.
I think Anne was going to do a short introduction.
Great, Anne.
All right, starting video. 1 second here. All right. Well, I guess you can see my laptop. Sorry about that. Are we good, Carol?
Yes, Anne, we're good.
Thank you. All right, let's do this. Good morning, and thank you so much for being here. We are excited to share information from Dr. Jonathan Lifshitz, and I'm Ann Tarpey, the Executive Director of the Governor's Council on Spinal and Head Injuries, and I have the privilege and honor of introducing Dr. Johnny, as we affectionately call him. And he has, at his very young age, he already has an illustrious career, but the only part of of his career that we'll focus on today in terms of his bio is that he is going to share some research he's been doing since he started this project in 2014. So Dr. Johnny, here you go. and I will get off screen.
Thank you, Anne and Carol, and the organizers of this conference, and including the Brain Injury Alliance of Arizona, which has been a critical partner in this. I'm thrilled to be here and represent a variety of institutions, and particularly my research team, which we refer to ourselves as the Neurotrauma and Social Impact Research Team. As Anne said, we transitioned from looking at neurotrauma from a variety of different sources to neurotrauma in individuals exposed to intimate partner violence about 6 or 7 years ago. And here to give you an overview of the state of the field, some of the primary concerns and the considerations that are provided or have to be taken into account when we consider individuals who are exposed to intimate partner violence. And just as a heads up, in this topic, as in any topic on intimate partner violence, there are trigger points and warning points, and I invite you to step away if this topic doesn't sit well, and to reach out for help, because there are many organizations that can provide help to those in need. So the first component that we need to discuss is the traumatic brain injury itself, just to give us a framework in terms of what we're considering. When it comes to traumatic brain injury, we think about all of the risk factors that go into initiating a traumatic brain injury that include lifestyle behavior, the biology, the genetics, and the environment, as well as the activities that somebody is engaged in. And those risk factors can include drug use, whether it's illicit or prescribed, dehydration, mental disorders, genetics, hypertension, anything that we're living with. And when it comes to inducing or receiving that traumatic brain injury, without a doubt, any injury results in pathology. And some pathology will naturally recover, and some of it won't recover and lead to an impairment. We can think about this in terms of a joint or a limb where pathology can either recover or it can leave you with persisting ailments. And if there is an impairment, it will lead to a functional limitation. And once those functional limitations are identified, the possibility exists to engage in rehabilitation to try to overcome those functional limitations. And anything that is remaining would be part of a disability that would affect quality of life. So when we talk about traumatic brain injury, there are individuals who naturally recover through therapy and rehabilitation, and there are a subgroup of individuals who have some ongoing disability that reduces or somehow impacts their quality of life. And we also have to take into account that all of the risk factors, dehydration, malnourishment, genetics, may influence the degree of recovery and responsiveness to rehabilitation. So that's the overall scope of how we consider traumatic brain injury to be a turning point in someone's life, and that risk factors go into the event itself as well as the recovery from the event. And when we talk about traumatic brain injury, historically it was car accidents, whether it was drivers or pedestrians. It's also been in the military, whether it's during basic training or during conflict. It could be during athletics, both organized and recreational sports. And today we're here to talk about intimate partner violence, which is particularly here physical violence between two partners that are in a specific relationship. It's also known as domestic violence or interpersonal violence. And for the most part, I'll try to use the term intimate partner violence. So when forces of a car accident or a blast or a sporting event or a physical assault occur, what ends up happening is that there are axons in the brain, and those axons can be stretched and torn in manners that are unique to the individual and to the injury itself, and those are scattered throughout the brain, and many people are working on that. The current state of knowledge with regards to traumatic brain injury is that that pathology that starts in the head can then travel throughout the body. And so on the right-hand side, you can see that traumatic brain injury starts in the brain, but then there's release of molecules into circulation that cause primarily an immune response. And then immune response can affect the lung, the liver, the bones, the digestive tract, the kidneys, and even potentially reproductive organs. So once you have this pathology in the brain and scattered throughout the body, the individual has or can display clinical symptoms of traumatic brain injury. And those symptoms fall into three broad categories. The first is cognitive, the way in which someone thinks or gets through their day. There are somatic, those are those in which the person is able to feel and engage in the world, which also includes balance and poor incoordination. And then the last one is emotional changes such as depression, sadness, nervousness, or aggression. And this makes sense because the brain does regulate all of these particular functions. And if we have that axonal injury scattered throughout the brain, there is the possibility for clinical symptoms to emerge. And so there's time for another poll question quickly. Aaron, there we go. So the poll question is, the research community has fill in the blank, more, equal, or less data on brain injury in women compared to men. And I know part of my research team is on and they know all the answers to these questions, as well as those that are participating. And it is true that there are less or fewer data on women in general in the research community regarding traumatic brain injury. So the vast majority of both clinical and laboratory studies have been conducted in males. Aaron, I'm going to end the poll. Oh, there you go. And so 90% of you are aware that very little work has been done historically to study traumatic brain injury in females, and there are pushes from all federal funding organizations to this extent. And so if we were to look at the history of traumatic brain injury, Sports Illustrated ran this cover article in 2010 showing how much, or showing that concussions in organized sports like professional football is an activity that is fundamentally changing the brain and also injuring and harming specific players. And this made a big splash and everybody said, oh my goodness, head injuries are important and we have to move forward. It's interesting to note that 35 years earlier, Miss Magazine put the concept of battered wives, a now old and arcane term for intimate partner violence, on the cover of their magazine as a result of research that was being conducted in London in the mid-70s. And I'll show you some of those articles. And so one of the take-home messages from this talk is that, like the news articles on professional athletes and soldiers, women and their families who are impacted by domestic and intimate partner violence are more likely to suffer a traumatic brain injury than the general public. And so you can see here that the Salvation Army has co-opted several different ad campaigns and internet memes to try to raise awareness with regards to domestic violence, which is often covered up as indicated on the right-hand side. And so this is one of those articles that led to that cover of Miss Magazine. It is an interview of 100 different women who were in a particular shelter, and these studies were run by Dr. Gayford out of the UK. And this narrative that I've put up here describes the complexity of the situation, that the individual was hit with fists and feet and bottles, that not only their head was then struck on the floor, sometimes there was kicking, there was broken ribs, there was strangle, which is the appropriate term, not choked, and then banging the head against the floor. There were constant bruises, even during pregnancy. There's black eyes, cut lips, and swollen noses, suggesting that those forces are being applied to the head. And most of them, where possible, were actually in areas that they don't show, such as behind the scalp line. And so many years later, in 1990, there was this one report of the pathological report of a woman who was determined to look like a punch-drunk boxers. And in this very short report, it says that the husband had been very violent towards her, particularly while drinking, and there's cuts and bruises. And the very bad histopathological images on the right basically show damage in the brain from of this particular woman that the authors concluded was a result of domestic violence. And then 31 years later, just last year, there was the second case of domestic violence pathology in a 29-year-old woman who died fatally after being thrown down the stairs. And the autopsy revealed that there's also similar pathology that you would not expect to see in a 29-year-old individual. And the fact that this individual also had those extensive scars under the scalp and cauliflower ears, which we know as boxer's ears, suggested that there was repeated violence towards the head. So now that we know that the violence occurs, the question is, what are the clinical signs and symptoms? In 2001, this particular article was published that shows two things. That when they went to speak with 52 women at a particular shelter, every single one of them said that they had received abuse associated with traumatic brain injury to the head. And then those that they were able to work with, which included 19 of them for various exclusionary reasons. I've highlighted in yellow some of the tests that show abnormality. And they're as simple as doing finger to thumb tests in terms of coordination, in terms of tandem walk, like walking on a line that you would see in an inebriation test on the side of a road, as well as some of the cognitive tests, such as memory recall. So there are certain domains that are showing impairments in these individuals. So the question arises, how many people are exposed to this type of abuse and these type of consequences? The epidemiology overall is very poor, but we can do some simple math and say that of all the people that are currently on Earth, roughly half of them are of the female gender or the feminine designation. We're excluding men at this point, but there is a population of men that are exposed to similar abuse. So that leaves us with 3.8 billion people, and the CDC estimates that 1 out of 3 women will be exposed to physical abuse at the hands of a partner at some point in their life. So 1/3 of that is 1.2 billion people who we would say are exposed to or at least risk for domestic violence. And when we dive into the literature and we try to identify how many individuals or survivors of this type of abuse have head or facial injuries, the numbers are 2/3 to 90%. So if we take that 90% number, we're still at 1.1 billion individuals who are at risk of a traumatic brain injury at the hands of a partner or an abuser. And so in one way, we can say that domestic violence, intimate partner violence, intensifies traumatic brain injury as a healthcare epidemic. And looking at it from another lens, traumatic brain injury intensifies intimate partner violence as a healthcare epidemic. And so both of these epidemics would qualify as a pandemic, a word that most of us have a visceral reaction to because of COVID. So then comes the question, what do you do once you learn about this information? What is it that drives you to get out of bed and make a difference? Well, the first things that we do is we start to write about it so people can read about it and learn about it. We were fortunate in 2017 for the Huffington Post writer Melissa Jeltsin to come out to Phoenix and talk to us about everything that we were doing and raise awareness, which then resulted in a series of articles and elevated awareness. And then with colleagues around the country, we continue to write scientific articles on the topic, first raising the red flag that this intersection does exist. In the state of Arizona, last year, we published an article where we were able to query data from our Arizona Department of Health Services. And we asked the ADHS for all individuals who were diagnosed with a concussion and evidence of domestic violence at the same clinical visit. So you would go to the hospital and by the time you left, the healthcare team would diagnose you as having both a concussion and a domestic violence diagnosis. This excludes anybody who didn't go, anybody who wasn't caught for both domestic violence and concussion, and suffice it to say there were about 1,000 records over a 4-year period. And on the right-hand side, I'm showing you the gender distribution between males and females, as well as the age distribution. And the most striking thing from this particular article is not that there were 1,000 individuals, but that it's mainly our infant and toddler boys that are receiving this type of injury, and then it's women of childbearing age, regardless of year, who are subject to this particular trauma. That being said, there was another hidden gem in this particular data, and that is that 23 of these 1,000 individuals were also pregnant at the same time. And I showed you that case study where the individual said that it even that the abuse included during pregnancy. And so then the question is, what happens to an individual who's in this type of relationship who is also pregnant? I'm going to use this slide first in the bottom left-hand corner to say that there are no race demographics, there are no ethnic demographics, there's no education demographics, and there's no socioeconomic status demographics for this group. What I mean by that is that there's no propensity for a specific slice of the population to be exposed to this type of violence and trauma. It is cross-cutting throughout our society. And then with that being said, this particular article looked at or interviewed pregnant women who were subject to abuse. These 24 women then reported where the abuse was occurring, and it still turned out that the majority of the abuse was being applied to the head, the neck, and the face. And so the question arises, are there any molecules that I showed you exit the brain and enter into the peripheral system or into the overall body that may then affect the developing fetus? This is a very complicated question and it's multi-layered. So the first thing that we were able to do was to model this in the laboratory. And so we published a paper again last year that mice born to mothers with gravida traumatic brain injury, this is a term that we're pushing, which means traumatic brain injury during pregnancy, and those mice have distorted brain circuitry and a change in their immune system. So we took pregnant mice, we induced a traumatic brain injury, those mice gave birth, and then we evaluated their offspring. And the primary reason for evaluating the offspring is to answer this question of whether there's transgenerational trauma, whether it's possible to inherit that trauma and stress. This is just the first study, and there's many questions to unfold, but quite simply, there is a cortical reorganization, so the brain looks different. The male mice particularly are more anxious, and that when we challenge the offspring with an immune response, so how well do you deal with sepsis or the common cold, the animals who were exposed to brain injury during pregnancy were had a change in their immune response, suggesting that there are transgenerational effects. So with this information and armed with this information, we went back to the Arizona Department of Health Services and we said, hey, can you give us the data on all pregnancies in the state of Arizona? So this is a 5-year period from 2016 to 2020. And in the state of Arizona, there were 336,000 pregnancies. Some of those pregnancies were from the same woman twice, which is perfectly normal. And during those pregnancies, so the 9 and 10 months of pregnancy, 19,000 had a documented domestic violence evidence in their healthcare record, and 10,000 had documented TBI, and another 1,000 had both DV or domestic violence and TBI. This means that roughly 30,000 individuals had this intersection of traumatic brain injury and or domestic violence with pregnancy, suggesting that 1 out of 10 pregnant women are exposed to this type of trauma. And so then the question is, and this is the next poll question, Aaron, is there's a variety of intake questions that we've had access to through our work with the Sojourner Center in Phoenix. And so I want to see if our attendance today can predict the similar outcomes. So there are actually 4 questions in this poll, and just select which range of outcomes in terms of the percentage of domestic violence shelter participants who receive medical attention due to domestic violence, and then predict how many or what percentage of domestic violence participants had talked to a medical professional at all about domestic violence, and then what percentage of domestic violence shelter participants were pregnant during a relationship that involved domestic violence. And then the 4th question is percentage of individuals who had a miscarriage during their relationship as a result, or during a relationship that involved domestic violence. And this is for my own edification to see if my preconceived notions were valid and true. So I really appreciate you answering this. So far, we have 19 of 31 participants having participated. Understanding that some of you may have challenges finding the poll. So to keep moving forward, responses are slowing down. I want to give everybody all the time that they need. It's really cool. I don't know. I don't think you, the participants can see the numbers changing in real time, but we definitely can. So each of your responses make a difference. So we worked with the Sojourner Center, and the Sojourner Center has some digital records on their participants. So we were able to gather their data from approximately 2015 to 2020, which is about 6 years. They had 7,700 participants who were answering these 4 intake questions. And it was surprising to us when we looked at the data that these individuals never received any healthcare result, specifically for domestic violence, that 2/3 of them didn't receive it. Your answers are between 1 and 99%, which is great. Whether someone had just talked to someone about domestic violence is still down at 2/3 have not spoken to a healthcare professional, which is cause for concern and a need to increase the amount of education on this topic so that healthcare providers are more comfortable. Has a participant ever been pregnant during a domestic violence relationship? The answer was 1 out of 2, which was mind-blowing in this population of almost 8,000 people. And then miscarriages were 16%, suggesting that there is violence sufficient to cause the miscarriage. So that was at the local level. At the more national level, there was a push by 2 senators, one out of Nevada, one out of Iowa, to engage the Government Accountability Office to say, go tell us what we know about this topic of domestic violence and traumatic brain injuries, because it affects the health and overall well-being of these individuals. This was in 2018. By 2020, the GAO report was released. It's this GAO report 20-534, came out a couple months after the lockdown, and so it really didn't get as much steam as we were optimistically hoping for. The main result that I'm showing here is that their conclusion was we need more data. We just need to be better at collecting, analyzing, and using that data to change the way we move forward with regards to first of all, the prevalence and then the services. And the 3 images on the right from their front page actually comes from work that Rachel Ramirez has done in Ohio, and she will be part of the session, the next session, talking about all the things that the Ohio Domestic Violence Network has done to train people to be more alert to identifying symptoms and then treatment approaches for traumatic brain injury. At the same time, we organized a national entity called the Global Neurological Epidemic and Abusive Trauma that brings together experts to try to understand best practices moving forward. Concurrently, an organization known as Pink Concussions that primarily focuses on women traumatic brain injury organized their partner-inflicted brain injury task force that again brings people together to have conversation. In Maricopa County, we organized the Maricopa County Collaboration on Concussion from Domestic Violence that I'll show you in a second. And just about 4 weeks ago, there was a long form article in the New York Times Magazine where Krista Hillstrom wrote about the personal effects of traumatic brain injury during domestic violence and opportunities to understand how to move forward. And all the partners you see on the screen were part of that long form article. In Maricopa County, the way that we work is that we educate our patrol officers so that when they go to a domestic violence call, they can be more alert. And Sergeant Lamelli said that just by having the training and being alert to the fact that we understand that some of these individuals could be subjected to traumatic brain injury, says that you view those individuals differently, that they're not being uncooperative, that in fact there's something going on inside their head and it's just not coming out. And so to support those patrol officers, there's actually hosts of social workers that work directly with the patrol officers and the police force in order to better serve the victim in those situations, as well as social workers at shelters for individuals who are seeking refuge. And then we educate with the forensic nurses, as well as the emergency departments, to be more attuned to and alert to identify and then suggest interventions for these individuals. Working with concussion centers throughout the valley to inform them that the diagnosis and treatment of individuals in this situation are similar to, but drastically different to, the athletes that they typically treat. We also are led by the Maricopa County Attorney General's Office, primarily by John Eliason and Hillary Weinberg, who are looking to change statutes about the implications of abuse. And then all of the data is run through the Cactus Foundation and the University of Arizona. Within the VA, since this is a VA-sponsored event, very excited that Kathy Doyle will join us in the next session to talk about the Intimate Partner Violence Assistance Program, IPVAP, which the VA has said that under no circumstances would any veteran or their family or caregivers who receive care, or their caregivers through the VA, or even the employees at the VA, would experience this type of violence. So this is both a patient and a provider type of opportunity to be able to provide person-first, veteran-centric, recovery-oriented, trauma-informed services. And those services at this current time are primarily through toolkits, fact sheets, and health and safety assessments, as well as groups and group-type therapy to be able to move forward from this. And then there's an interesting component that we need to consider, is that in our legal system, people are innocent until proven guilty. And that makes sense. In the healthcare system, when you walk into a healthcare provider, for all intent and purposes, you're healthy until proven injured or have a disease. It's basically a diagnosis of inclusion, that if your tests come back a certain way, you are included in a particular disease mindset or a disease category. But if we flip that on the head and say that a person actually is injured until proven healthy, or in this fact, has a traumatic brain injury until proven healthy, much like Sergeant Lamelli said about the victims that he faces, that we have to be concerned about that. What this actually means is that we are advocating that any individual who experiences intimate partner violence should be tested for traumatic brain injury, tested using objective tests that reduce reliance on patients' self-report, because we know that there can be issues and errors in there, and that we're going to approach that examination with a diagnosis of exclusion, meaning you are brain injured unless you pass every test. And the benefit of this is that fewer people who experience intimate partner violence are going to go untreated for traumatic brain injury. And so the current state of the world is that very recently, Senators Ernst and Cortez Masto are now taking that GAO report and pushing it forward into a bill that is in the legislative process. And quite simply, the bill would force the Department of Health and Human Services to collect specific data on brain injuries from domestic violence, as well as allocate resources to reduce, meaning prevent, and treat these injuries moving forward. So if you hear about this, please advocate for it. And what do we do about our particular survivors? Well, when we look at guidelines for traumatic brain injury, whether it's pediatric brain injury, whether it's sports, whether it's car accidents, both of them have this concussion protocol type of approach. On the left-hand side is a pediatric roadmap from brain injury to recovery, and on the right-hand side is this athletic type of recovery. And basically it's take it slow, in terms of how much exertion you put forward before you return to play, return to school, return to work. Basically, shut down your life for a while and allow your brain to recover and heal so that you can get back to your life. But when we think about treatment for the population of those who experience intimate partner violence and traumatic brain injury, is graduated return and rest really possible? So when we think about our own frantic lives and potentially the fractured lives of those who are in these challenging relationships, when you're juggling work and chores, when you're juggling multiple people's calendars and pets, and then we put on top of it all those risk factors we had at the beginning, the genetics, the mental health, the drug use, sleep deprivation, it's probably not an effective approach. And I do know that the IPVAP through the Veterans Health Administration is working on ways to support individuals who are in harm's way so that they can recover. Right now, it takes a lot of listening. Right now, it takes a lot of conversation and work together to provide the support, because there is no standardized support system. And we wouldn't expect a standardized support system, meaning out of the box, just follow the protocol, because each person and each injury and each situation is different. And that's the end of my talk. Again, I'm here representing my research team, NeuroTrauma and Social Impact Research Team, and privileged to work with the Phoenix VA, the College of Medicine, as well as Phoenix Children's on this and other topics.
Thank you, Dr. Johnny. This is the time that folks can add some things into the chat. We've really not really had any questions, but we did have somebody comment. Let me get back up there. We had an individual share that she is a TBI survivor, and that other conditions, bipolar, for example, can be exacerbated by a TBI. In her case, she had mild bipolar, but that it went undiagnosed and was nearly asymptomatic. But then after her head injury, her bipolar became more severe and caused her to be disabled. Any comment on that, Doctor?
I'm reading through it as well as you were talking through it, Carol.
Mm-hmm.
Thank you very much, Susan, for sharing that with us. Anything can happen after traumatic brain injury. So you can have underlying conditions that are not necessarily affecting your day-to-day activities or your activities of daily living that can either go away or be exacerbated after injury. What I'm very optimistic and hopeful about the story that you put into the chat is the fact that you sought treatment, you got the treatment that you needed. That's the way I understand it, and seeking treatment and receiving that treatment is the ultimate outcome in these types of situations. And Susan, you're not alone. There are many other individuals whose mental health conditions do change as a result of traumatic brain injury and end up dealing with new mental, neurological, and psychiatric conditions, or at least are new to them because they weren't caught beforehand.
Dr. Johnny, can I just comment that if Susan needs additional support, that Janice from the Brain Injury Alliance of Arizona is here. And if she hasn't reached out to the Brain Injury Alliance before, Janice is their peer and their staff person that really that is amazing to work with victims of domestic violence who also have brain injury.
Yeah, I'm personally grateful to Carrie Collins, who has broadened our view on traumatic brain injury or brain injury in general in the state of Arizona, and making sure that we are reaching the diverse population who are affected by traumatic brain injury. So Susan, you added additional statements on here, which I think are worth pointing out, that you receive treatment for your brain injury, you receive treatment for the psychiatric component, but you didn't get treatment for the domestic violence. And that is honestly what irks me as well. When I have spoken with physicians in training and they're just uncomfortable talking about these topics, and they are uncomfortable topics, it gets pushed more to the side rather than being elevated as a primary concern that requires treatment. And so the only thing that I can tell you is that I'm in conversations with the College of Medicine in Phoenix to at least make this part of the discussion so that our future physicians are more comfortable identifying it, providing resources, and being able to track and monitor it for not only you, but others in the future.
Thank you, everyone. I am trying to put the evaluation link in the chat. We want to be sure that you please do that before you head to the next session. Thank you for sharing your story, Susan. Any other questions before we let you go, or comments? Catherine Doyle put some info in there about following up with her and her program, and she will be talking in the next session. So be sure that you join us for that, should you want more information. And I'm putting the Survey Monkey in the chat.
Thank you all for coming. Thank you all for listening. Thank you all for growing your advocacy towards this topic. This is a topic that impacts our lives at every level. And no matter where you find yourself, there's an opportunity to advocate for more resources, whether those resources are education or services or physical resources or research, anything to that effect. This is a societal issue that we can tackle.
And the more of us working together, the better off we'll be. Is that correct, Dr. Johnny?
Mm-hmm.
Yeah.
Yeah. And I do want to just give a promo for the next session. So Dr. Johnny will be with us, and then we have other subject matter experts, including Rachel Ramirez from Ohio, and Dr. Doyle will be there with us from the VA, and then Janice and Carrie from the Brain Injury Alliance will be there to talk to us. So thank you so much, Dr. Johnny. This is a difficult issue, but so important for all of us to understand and start working together differently and better.
Thank you so much, everyone. Have a good break, and hopefully we'll see you in the next session. And if not, have a fabulous, beautiful day.